Fenton. I am from the University of Texas Health Science Center in Houston at our School of Biomedical Informatics, and so very happy to be here today and to have all of you with us today. We have two presentations for you in this next hour. It is my distinct honor to introduce our speakers and to moderate this session. So first, we have for you an infodemic leveraging high-volume Twitter data to understand early public sentiment for the coronavirus disease 2019 outbreak, presented to you by Dr. Christoph Lehmann. He is the Willis C. Madry, MD, Distinguished Professor in Clinical Sciences and the Director of the Clinical Informatics Center at the University of Texas Southwestern Medical Center. He conceived and launched the journal Applied Medical Informatics, devoted to original research and commentary on the use of computer automation in the day-to-day practice of medicine, and he served as the editor-in-chief since its inception. Dr. Lehmann's research focuses on improving clinical information technology and clinical decision support. Please join me in welcoming Dr. Lehmann.
It's projecting well.
Chris, we are seeing your speaker notes. We are seeing the speaker version.
Oh, okay, thank you. So I'll stop sharing and try that again. You're still seeing the speaker version, are you?
Swap your display up in the upper left-hand corner where it has display settings. If you would swap the display, that would probably work.
Okay.
So, yep.
There we go. Thank you, Susan. All right. Well, thank you for the kind introduction, and it's my pleasure to speak to you today. And I think it's hard to follow such a dynamic speaker as Nora Belcher, who delivered an exceptional keynote. First, I would like to mention that my colleague Richard Medford was supposed to give this talk, but he's unfortunately detained. So this is part of a larger corpus of work on COVID and consumer informatics that we've been working on here at the Clinical Informatics Center at UT Southwestern. You will hear later today from my colleague, Sam Soleil, who will talk about our work in crowdfunding. Disclosures, I serve on the board of directors for another few months for the International Medical Informatics Association. My wife and I own stock in Markel and Celanese corporations. I've received an honorarium from Springer for publishing a textbook on pediatric informatics, and you heard that I'm the editor-in-chief of Applied Clinical Informatics. So let's talk briefly about the epidemiology of a pandemic. How contagious a virus is matters. One single infection has triggered a worldwide pandemic in a matter of a few months. Recent evidence shows us that the first COVID infection in the US actually occurred as early as January 2020, not in March as we previously thought. We measure contagiousness using R0. Fortunately for us, the much deadlier Ebola virus has a much lower R0 than the original COVID or the new Delta strain. On average, every infected person with a Delta strain will infect 7 other susceptible people, making Delta a very contagious virus, as seen by the current spike in cases that we are currently experiencing. Measles and mumps are more contagious, but they're a lot less lethal. And thanks to childhood vaccines, we have a substantial herd immunity there. Flattening of the curve matters, as it affects the way our healthcare system is used. You may have heard in the news that Idaho recently, I think yesterday, enacted a crisis standard of care. That's not the regular standard of care. It's lower than what we usually practice. Idaho's patient numbers have exceeded its hospital capacity. Using non-pharmacologic measures like masking and social distancing can flatten the curve and can avoid overburdening of our healthcare systems. And that's why it's so important that we understand what people think. Public perception matters. It matters because it affects sentiments, which in turn affect behavior. Facts are unfortunately only secondary more often. So understanding the public sentiments and opinion is critical for public health and for government officials, because it will have an impact on how people behave and act and what resources are needed. the United States has been really disproportionately been affected by COVID. There were 200 million cases worldwide and 4.5 million deaths as of August 4th. However, the United States had 17.6% of all cases and almost 15% of all death, even though we only represent 4.3% of the world population. And I believe that this proportionate way we have been affected is a function of our belief and our opinions, and understanding those is a critical first step. So we're breaking this talk up into 5 sections. Making sense of Twitter data, talk a little bit about natural language processing that we leverage for that, talk about the understanding of COVID public sentiments or results, talk about some consideration barriers, and then talk about future work and applications. So social media has been described as an interactive digital technology that enables the creation, sharing, and exchange of information, ideas, opinions, thoughts, and other form of expression in form of text, images, audio, videos, via virtual communities and networks. Social media allows users to exchange and further distribute user-generated content, such as posts, comments, digital photos, videos, and data generated. So it's a great place to learn what people are thinking and thinking about. Data obtained from social media posts and interaction has been shown to complement and enhance disease surveillance, for example, of infectious diseases like Zika, dengue, Middle East respiratory syndrome like MERS, and Ebola virus. The first social networking and video sharing platform, Bulb, was developed in 1996. Since then, almost 4 million people worldwide have become active social media users out of 7 billion. Globally, the average person has almost 9 social media accounts and spends over 2 hours engaging in social media per day. I hope that you all are tweeting about this conference. The hashtag is THIA21. The most popular media platform, Facebook, has almost 3 billion users, active users. And the popular video platform, YouTube, has 2 billion active users. The growth of social media is growing everywhere in the world. So let's talk about the social media platform that we use, Twitter. Twitter has 1.5 billion registered users and 330 million monthly active users. And 145 million are daily active users. 63% of Twitter users are between 35 and 65. The median age is 40 of Twitter users. 20% of internet users in the US access Twitter on a monthly basis. And the amount of tweets that we send is enormous. Almost 6,000 tweets per second are being pushed out. So a lot of data available. So let's deconstruct the tweets. So there's lots of information in the tweet. There's the username, the text and hashtags, the media links, date timestamp, and the source where it was generated, and then the retweets, the quoted tweets, and the likes that the tweet has. And Elon Musk might have been to space and he might have produced a car that's very popular, but he clearly missed the boat on this tweet. So when ingesting the tweets, our main object is the tweet object itself, and it has a lot of attributes to it. But each tweet also has a user that has generated it. If there's a place that's associated with it, if it's geotagged, that information is available. And it has the native media that is attached to the tweet if you add an image or GIF, a video, or something else. We use the Twitter API, the application programming interface, as a tool to get the data. And we applied for a developer key, and then we can use that API to pull tweets into our local database and analyze them. We are mainly concerned with the GET method. There are other methods to interact with Twitter data, and there are multiple APIs that Twitter offers. Just to give you an overview, streaming API gives you essentially real-time tweets as they happen. You can go back as far as 7 days. You can search for tweets, and there's the Firehose API, which gives you a random sample of 10% of tweets on a certain topic that you're looking for. Well, we used queries, and then we got the tweet subject back, and we parsed them. They come back as a JSON file, and we parse them and put them in our database. So now a quick course on natural language processing, NLP. Natural language processing is simply programming a computer to process and analyze large amounts of data. In this case, we use it to analyze large amounts of natural language unstructured data. This encapsulates a lot of application ranging from speech recognition, like your Amazon device does at home, to text generation, to content analysis. In this context, we focus on content analysis, obviously. The core unit of the analysis is each document of text, and multiple documents of text make up a corpus. In our case, one tweet we call one tweet a document, and the data set of tweets is the corpus. The first big part of the analysis is to extract the syntax from the documents. So the initial steps involved that we did data cleaning. That means we went ahead and removed stop words like is, the, of, so words that have little analytical value. We removed hyperlinks and non-alphanumeric characters like emojis. And then we used lemmanization to return the root form of a given word. So the word went turns into go. And we then used stemming to chop down the word to its base. So lemmanization converts the word, which makes the stemming faster and more rigid. And then we can break down the text into terms, single words or unigrams, or 2 words, bigrams, etc. So these tokens then can be used and analyzed. We evaluate the frequency of certain words or tokens and search for particular keywords to see if they're present in the text. And then we can take all that and see how all these tweets relate to each other using topic modeling. So we automatically identify abstract topics by detecting word and phrase patterns among the document. And the goal is to find hidden topical patterns that present in a collection of documents, and then annotate and sort these documents accordingly. And that way you can summarize large corpora of documents. So we then did a bunch of further analysis. We did sentiment analysis on those tweets. Typically, this is done by using previously trained machine learning models to label each document. So we can evaluate polarity or valence to label a document as negative, neutral, or positive. We can also label emotions. So this is often done with well-known emotion schemas. And we also can identify subjectivity or objectivity of a tweet. So then we can also, you heard me say, we can see how different documents relate to each other. And this topic modeling seeks to identify the topics by detecting these words and phrases among the documents, and see what topics emerge as the most popular and most prevalent ones. And we can then use those topics to actually analyze and summarize our collection. So let's talk about the results that we did when we did our COVID-19 public sentiment analysis. We went into this very early. I was obsessed, I have to share with you. I was obsessed with COVID back in December of 2019. I started stocking up on food and toilet paper in January of 2020. And it was only logical that at that time we started to think about, what's going to happen to that COVID thing, and what's going to happen to the public perceptions of that. So we analyzed 126,000 tweets. We looked for hashtags of 2019, COVID, coronavirus, the most popular hashtags that were used. We searched the dates from January 14th to 28th, so only a 2-week period. very early on in the pandemic. And it was very interesting for us to see that as the number of confirmed cases per day of COVID was increasing worldwide, the number of tweets that we saw, and we only use English language tweets, the number of tweets that we saw increased in parallel. And you can see the first case in the China outbreak outside Wuhan was on January 19th. There were 3 deaths at that time as well. Then on 23rd, you had the cases in Singapore and Vietnam. And then they stopped all outbound travel from Wuhan. And then you had the first cases in Australia. So you can see each of these events created spikes in the number of tweets that we could see. When we looked at the sentiment analysis, we were actually somewhat surprised. Well, somewhat and somewhat not. For both, we trended the daily number of tweets labeled with each emotional valence. For the emotions, we used a classification system that includes the emotions of anger, disgust, fear, joy, sadness, and surprise. And fear was the prevailing emotion in nearly 50% of tweets. And it increased at a faster rate than the other emotions. The next common emotions were surprise and then anger. Similarly, tweets with negative polarity were most common, and they were increasing at a faster rate than positive or neutral tweets, as you can see on the right. On the topic modeling, we used an unsupervised machine learning algorithm to optimally identify 10 topic classes that we have here. And the topics were ordered in the frequency of how often they came up. So you can see the most common topic was the discussion of economic and political impact in the beginning. You know, when we didn't have any cases in this country really yet, that was, you know, what is it going to do to global trade? What is it going to do to travel, etc. And then government response was the next most pervasive, while discussing of the public health risk, and the index cases by country were the least common. We visualized the topics and monitored the incidence of topics over time. And topic clusters, they included themes of outbreaks and this transmission, public health risks, and the index cases were discussed from the start of the study period. And then later on, we saw discussions of quarantine, economic and political impact, government responses that were in the second 2 weeks. So this discussion clearly evolved as people understood more and thought more about it. We also then subsequently looked at social distancing on COVID. There we took a period in March and April of 2020 and analyzed close to 600,000 tweets that had the hashtag social distancing and stay at home in their words. And you will notice that on this word cloud that we created, the bigger the words are, the more common they were found in the tweets. And we also, again, performed sentiment analysis and presented the frequency of each emotion and polarity. Overall, Twitter users reacted at that time fairly positively to social distancing with a predominance of positive sentiment. It's the people that liked it that were talking about it. The pervasive emotion was actually joy in nearly 50% of the tweets, and surprised followed by that at around 20%. If you look at the subjectivity, tweets tended to be more objective in nature, and approximately 30% demonstrated near complete objectivity. The median subjectivity scores were similar for social distancing than they were for stay at home. So there was no big difference in those groups. And here again, we have the topics ordered by least frequent. This time we included the sentiment and subjectivities as well per topic. Discussion of public opinions as well as discussion of media and entertainment options were the most common topics that were discussed. Topic of public opinions was the most subjective topics. All topics were on the positive sides, but the discussion of quarantine, public opinions, and ordering supplies were more neutral and more negative. What really amused me when we were looking at this, so I'm the one in the group that always gets to come up with labels for the topics. I look at the words that contribute to it, think about it, look at sample tweets and say, this is really what this discussion is about, after the machine has generated these topic models. And the one topic model that I was amused by was that was a big discussion. It was the least common one, but still, people started to talk about, what am I going to do in my social isolation? How can I share entertainment like music and media with other people? So that was a big part of that discussion in the spring of 2020. So what are the considerations and the barriers to our work? Well, first of all, it's difficult to actually do the extract, transfer, and load process for the Twitter data, and we had problems where our data flow was interrupted and where things just broke. It's a complex process, and it's labor intensive and requires a lot of computing power and a lot of data storage. But it's only a single data set. It doesn't reflect the users of Facebook that are different than the users of Twitter. So it's not representative. You have a lot of opinion leaders, people that loud and tweet frequently like me, that can impact the topics and the perceived public sentiment. And you have significant limitations in the natural language processing. They're synonyms, irony and sarcasm. We just discovered, we were looking at tweets related to the hashtags plandemic and scamdemic. And we discovered that our machine learning tool that was looking for emotions completely broke down, because irony is really, really hard to analyze. And and there are things in machine learning. This is a story. The validity of that is somewhat dubious, but the story is that Mark 14, verse 39, the spirit is willing, but the flesh is weak, was translated into Russian as the vodka is good and the meat is rotten, while we're dealing with the same limitations in our NLP work. Let's talk about the take-home and the future work. Well, our future directions is that we want to look and develop a specific sentiment and emotion model for tweets that are related to emerging healthcare outbreaks. We believe that actually requires its own keywords and in its own machine learning approach. We are very interested in further working on geospatial analysis of Twitter topics pertaining to COVID and the sentiment over time. We think that it's going to be useful in analyzing local reactions. When it comes to local, the crowdsourcing that you will hear this afternoon from Dr. Saleh will show you that these kind of approaches actually can identify communities in crisis early on. We are interested in misinformation and identifying it, and maybe even combating it with automatic Twitter bots that respond to tweets with misinformation. And you will hear later about our analysis of GoFundMe campaigns and how they how the crowdfunding campaigns responded to the COVID pandemic. So at this point, I think I am out of time. I left 5 minutes for questions, but I wanted to thank my colleagues at the Clinical Informatics Center at UT Southwestern. I want to thank my fellow planners at the Texas Health Informatics Alliance. And I want to thank you, the audience, for showing up today and making this conference a success. And if you have any questions or comments, please email or tweet me at CU Lehmann. Thank you very much.
All right. Thank you so much, Chris. Very, very informative. And thank you for tracking it from the very beginning. We're glad you were obsessed with it. So we do have time for a few questions. Please enter it in the Q&A. Catherine, do we have any questions?
Yes, we do. From Susan Saniel, she says, I think with increasing access, it's important to be upfront with the final cost for the consumer. That way they can make more informed decisions about how they spend their money for healthcare, like on Amazon. You can compare prices, read reviews before purchasing. Oh, I'm so sorry. This might be for Nora with smartphones. I'm just going to jump to the next question, which is about PowerPoint presentations. Yes, we can share those after the conference. In light of that, Chris, do you want to weigh in on the last question, or?
Yeah, I just wanted to, the cost for COVID is becoming increasingly important, and it's also being discussed at Twitter. One of the most recent works that we did looking at mentioning of insurance and employers, it's actually that question about the cost to consumer made me think about that, showed us that we are starting to see more and more corporations increasing their healthcare expenditure for employees, the part that the employees have to pay for health insurance, for employer-provided health insurance is increasing for people that are unvaccinated. That's a common trend that we just recently identified on Twitter. Based on what I can see, as according to what people say, it's almost in the order of $200 a month if you're not vaccinated, that your employer is penalizing you for your insurance premium. So it's kind of interesting to see that. Before, I've seen this actually as a big discussion in the newspaper, that we are able to pick up that trend on Twitter already. If there are no other questions,
there is a question. How many researchers are interested in combating misinformation? Are there strategies already in place? If you can't fix that, physicians will lionize you.
Yeah, so one of the people that I follow closely on Twitter, who is doing a tremendous job, is our keynote speaker this evening, Dr. Hotes, who is really waging a one-man war against misinformation on COVID on Twitter. However, we have been actually thinking about this, and we're working on a grant application to create a bot that will monitor Twitter in real time for misinformation tweets. So we'll have to train it to identify misinformation, and that will have a series of responses depending on the topic that can be tweeted back that actually provide actual information. We believe that in a medium with this kind of volume, the only way of combating misinformation is actually automating it, partnering with experts like Dr. Hotes on identifying the best information that can be used to combat misinformation, and weaponizing ourselves using bots to combat that. So that's really the only solution that we see, because otherwise a one person war on this, if you're as popular on Twitter as Dr. Hotes, that might have some impact, but for most of us it doesn't. So doing this automatically is probably the solution going forward.
Thank you for that. And I'll also note that Dr. Bill Turney, from who will be on our panel this afternoon, said there is a group of investigators in UT Austin's iSchool who focus on misinformation and how to combat it. So I think we're definitely seeing people interested in taking on this issue of misinformation. All right, well, there are no other questions. Thank you very much, Chris. We so enjoyed your presentation and look forward to reading or hearing your further work on this as your research progresses.
Thank you for having me.
You're welcome. And with that, we are now ready to move to our next presenter, and that is Dr. John Robert Bautista. He is a postdoctoral fellow at the School of Information, the University of Texas at Austin. His research focuses on the role and impact of information and communication technologies, such as social media, smartphones, and blockchain, among healthcare professionals and consumers. He also conducts new media, location-based advertising, social TV, health communication and informatics, mHealth, eHealth, and nursing research. So with that, please join me in welcoming Dr. Bautista. Thank you for being here, Dr. Bautista.
So thank you very much. Are you able to hear me right now?
I am able to hear you and
Yep.
see you and see your slides. Thank you very much.
Okay, great. Thank you very much for the invitation on sharing my work here in terms of misinformation. So as Dr. Lehmann mentioned, there are two ways that we can actually combat misinformation. One is algorithmic interventions. It means the use of bots, which is much more automated. And one is what we call social correction. Social correction is primarily done by other people who would correct others in terms of the misinformation. So the title of my presentation right now is about healthcare professionals as digital first responders in fighting COVID-19 misinformation on social media. And I'll be sharing some of the lessons learned from a mixed method research that I've done for the past couple of years. So to start with, there is no set definition of what health misinformation is. Misinformation per se means that it's a misleading information that might be sent intentionally or unintentionally. But to provide so that we are on the same boat in terms of health misinformation, we would define it as any health-related claim or fact that is false based on current scientific consensus. That's based from the AJPH article by Chow and colleagues. So the problem with health misinformation is that once you get exposed to it for some people, so it's really interesting that there's this one report from the Center for Countering Digital Hate that a bulk of the misinformation, health misinformation, disinformation is produced by what they call the disinformation dozen. So it's mostly about anti-vaccine content. So once you get exposed to it, people can have poor behaviors towards it, like what we're experiencing right now in the US, which is the vaccine hesitancy. And that poor behavior can lead to really poor health outcomes that people are dying, and most of those that are reportedly dying are those that are unvaccinated. So we can see that exposure to misinformation has a certain link to poor health outcomes with this mechanism. So moreover, the United Nations, along with its agencies, more specifically the World Health Organization, has somewhat recognized misinformation as a public health threat. Even before the COVID-19 pandemic happened, there has been some issues in terms of vaccine hesitancy. And it's only a matter of time that this becomes a problem. Then suddenly COVID hits and they realize that it's really a public health problem. So they think of COVID-19 as a public health issue. And one of the initiatives that they did was that to initiate the digital first responders. The digital first responders means that these are people that would actually share correct information, and hopefully that would correct misinformation on social media, because the principle of social correction is that some people might trust other people, and once you trust that person sharing that kind of information, which is hopefully true, you're more likely to adhere, you get more likely to be persuaded by that information. So nonetheless, in a recent report by in a recent advisory by the U.S. Surgeon General, although they view confronting health misinformation as a multisectoral approach, so it's not only individual families, it's not only social media companies, they also emphasize that health professionals can do about it, and healthcare professionals need to proactively engage with patients and the public on health misinformation. And they actually specify that health professionals and even health organizations should be in a place where people are, meaning that they need to use technology and media platforms to share accurate health information with the public. And we need to work together as healthcare professionals to do this. So we also need to train our healthcare providers or professionals on how to deal with misinformation and what to do about it. What are some of the strategies to use in terms of correcting health misinformation. So that is one of the most recent developments on why healthcare professionals need to be on social media. And we've been hearing lots of news reports. Some journal articles are also urging healthcare professionals to be on social media and help correct health misinformation. So it's not only Facebook, Twitter, but there are new social media platforms. For instance, there's some doctors that appear on TikTok that they share health information on that platform because those are where people are right now on TikTok. It's not only about teens. There are some also younger adults and even older adults that are using TikTok because it's something that's currently um, very in platform right now. So the difficult thing about this is that not only are healthcare professionals like nurses, doctors, and other healthcare professionals fighting COVID on the front lines, they're also fighting it on the digital front lines, which is primarily on social media. So in this talk, I'll be sharing about some of the things in terms of my research. So at the end of the presentation, hopefully participants will be able to first describe the process of correcting health misinformation on social media, list some of the factors that are associated with such intention to correct it, and identify some of the strategies that can be used to mitigate health misinformation on social media. So if we want to make some corrections, we need to do certain actions for it to be corrected. Now, moving forward, um, the research that I'm presenting right now is based on a mixed method research on healthcare professionals, digital first responders in fighting COVID-19 misinformation, social media, and it's composed of three interconnected studies. The first study asked about how do U.S. healthcare professionals correct health misinformation on social media, and I did this on the wake of the pandemic. Actually, when I did this proposal, there wasn't COVID yet. I was moving towards the direction of vaccine hesitancy because WHO, even in the early 2019, has been saying, or even in 2018, has been saying, health misinformation will be a big problem in terms of vaccine hesitancy. Then, when I got my IRB approval in in December, then I did the study on January. Then, boom! Suddenly, COVID happens. Then the the focus of my study suddenly, not, it didn't really shift, but it became much more focused on COVID. So I did interviews with doctors and nurses, and some of the doctors and nurses here have substantial social media following. I think the highest that I have is like more than 100,000 followers on Twitter. So most of them are Twitter users, but some are TikTok users, some are using Facebook, a really large variety of social media. Some are using Doximity and other social media platforms. Next, as a follow-up study based on that qualitative interview, I actually did a survey among healthcare professionals, an online survey, which since the goal is to identify some of the factors associated with their intention to correct health misinformation on social media. So previously, I only interviewed some, got some idea on some potential factors. Then I tried to do it to try to establish, using survey data, what those factors are. So somewhat study one, study two is interconnected. And I also aim to know what are some of the strategies that most of the healthcare professionals use to correct health misinformation on social media. And on a follow-up based on the results of study one and study two, I did an online experiment wherein the aim is what correction strategy is effective in increasing US adults' intake to take a COVID-19 vaccine. So the timing of this experiment was really good because between April and May, that was the time that most of the adults will become eligible in the United States to have COVID vaccine. So there's no more prioritization in terms of vaccination. Anyone who is eligible to take the vaccine can actually have it. And I did filter the survey to only include those that are vaccine skeptic US adults. I collected the data using Amazon MTurk, and I was able to collect 544 respondents to answer that online experiment. So we'll go over some of the pertinent lessons that I gained from each of the study. And let's start with number one. So an interesting thing with number one is, how do you correct health misinformation on social media, at least from the perspective of the 30 healthcare providers? And I would suggest that you can read our article on International Journal of Medical Informatics, which is the Healthcare Professionals Acts of Correcting Health Misinformation on Social Media. But I would like to summarize that we would be focusing on the yellow part. This is what really answers the question. So how do you correct health misinformation on social media? It's a lot of process. It's like you identify whether this post is a health misinformation, then you do some correction preparation, but at the end, how would you execute that? And there are 4 ways of doing this. And this is what we call private priming, public priming, private rebuttal, and public rebuttal. So let's go over to the first correction method. So private priming is about privately posting. So there are some people out there that their Twitter is private, and if you post something on like Twitter and Facebook, if it's set to private or for friends only, there's limited reach. So it's only for close contacts. So you can actually post some credible information. You can post some evidence-based information as a means of priming against health misinformation. You're not necessarily correcting someone, but you're correcting the misinformation by posting credible information with the hope that somewhat this might drown the misinformation that's out there. The next thing that people do is public priming. So this one example of Professor Hotes in terms of doing public priming. So you just publicly post or share credible or evidence-based health information as a means of priming against health misinformation. So you just post and post and post with the hopes that it will be shared by most people and people would learn from it. Hopefully, it would reduce the negative impact of health misinformation. So priming means that you don't necessarily engage in a debate. You just post correct information. That's it. You can choose either private or public. The next thing is that it can be a private rebuttal, wherein you respond to health misinformation posts privately. So you can actually, this usually happens among families. So you don't really correct someone publicly if it's a family member. So you put them on the side, put them on like in the group chat, in a personal chat, a direct message. Then you discuss ways that you can provide correct information. So for most of my participants, they actually encounter this with relatives. They somewhat discuss it with them, provide them with health information that is accurate, so that somewhat the health misinformation would be, the effects will be reduced. The final one is doing public rebuttal, which means that you really reply to the person that's saying, this is not correct, and this is the correct information. So it's responding publicly to a health misinformation post, and you actually provide credible or evidence-based health information as a rebuttal. So mostly it's not sufficient that you just say it's wrong, but you need to say why is it wrong and what's your reference. So that's public rebuttal. Now, so we have your public priming, private rebuttal, public rebuttal, but based on survey, which among them are the ones that are mostly performed by healthcare professionals. So I based on the survey of 377 healthcare professionals, found that in general, most would agree that they intend to correct health misinformation on social media, as reflected by the blue bars. But among the blue bars, we would see that most of the people would intend to do public priming, followed by public rebuttal. So public priming is just you're sharing accurate health information publicly, while public rebuttal is really making a correction by posting a public comment or reply. So most healthcare professionals are comfortable with performing either public priming or public rebuttal, or in general, public means of social correction. Now, the next study focused on what are the factors that are associated with healthcare professionals' intention to correct health misinformation on social media. So there are 4 ways that they would correct health misinformation on social media, as mentioned earlier: private priming, public priming, private rebuttal, and public rebuttal. And I do realize that there are certain factors that would affect. One is organizational support, or at least the perception of organizational support. There have been some tricky news in terms of organizations trying to dictate what healthcare professionals should post on social media. And that's why I think that, based on the interviews also, that organizational support seems to have seems to be a factor on healthcare professionals' intention to correct health misinformation on social media, or in general to engage people on social media. And to a certain extent, it's not only the organization, but it also depends on the person's belief, like personal belief, like their instrumental or affective attitude. Instrumental means whether it's something that's doing this is useful. Affective attitude means do they feel that doing this is ethical and seems to be aligned with their professional identity. Next is injunctive norm, means that do other people expect them to do this? Descriptive norms means that are there other people doing this? And lastly, perceived behavioral control means that can I do this? Do I have the sufficient training and capability to do such a behavior? And I try to create a model out of it, and the results suggest that first, attitudes are important. So if if healthcare professionals think that correcting health misinformation, either from using private priming, public priming, or public rebuttal, if they will feel motivated to actually do those things, if they think that doing corrections is useful and ethical and it aligns with their professional values. Now, I would like to emphasize that the yellow highlights in the arrows means an indirect effect. So perceived organizational support does not have a direct effect on intention, but the mechanism is that if an organization like the hospital management, supervisors, co-workers, clients actually support that healthcare professional, if they think that they're being supported in doing that, they'll have a much better attitude on doing correction, and that positive attitude in doing it would increase their willingness to correct health misinformation using private priming, public rebuttal, and public priming. In another way, private rebuttal means that you send a private message to someone else, maybe a person that you know, maybe a person that you don't know, but it's a private message. So it's a different thing. It's much more about affective attitude, which means that you feel if it's something that's ethical and you feel that it's part of your professional identity, or descriptive norm, are others doing this? Or it can also be dictated by, can I do this? Can I interact with this person? Is it possible for me to interact with this person on direct messaging? Then you're more likely to do it. Then in some ways, organizational support also supports that kind of relationship, wherein you'll be more you'll have a more positive attitude towards it, more positive descriptive norm. You think that more people are doing it, and you feel that you're able to do that behavior if there's organizational support, or what we can call organizational backing. So in general, attitudes, descriptive norm, and perceived behavioral control somewhat has the capability to increase the willingness, and organizational support can somewhat increase those factors, the effects of those factors. Finally, I also did some experiment with US adults' intention to take a COVID-19 vaccine. So this experiment is about how persuasive corrections are when it's delivered by healthcare professionals. So I actually did a study wherein there's a control, wherein I showed some of these people the misinformation only, or I presented them with a public priming approach, wherein that public priming is shared by an individual, a registered nurse, or an MD. So if it's a registered nurse, I just place RN, then nurse Alex. If it's an individual, I remove nurse or doctor. So in the MD group, so what's written here is like Alex Williams, MD, Dr. Alex here. So it would have the same almost text. Then we also have this public rebuttal, wherein there's there's this misinformation on top, then there's this reply below, which simulates the public rebuttal. So all of these tweets are simulations. They're not real. They're just for the experiment. And based on the results, it's interesting to know that I look at the impact of those corrections in terms of intention to take COVID-19 vaccine. And I would like to see whether the mechanism of the evaluation of information and the perceived expertise would have an indirect effect on the dependent variable through those mediators. So moving forward, I also like to see whether the result differs from vaccine skepticism, whether it's high or low. Next, there's no relationship with when people are exposed to public priming or individuals or from the medical doctor or nurse. But what's interesting is that if people think that the information is credible, truthful, reliable, then they're more likely to take the vaccine. True, when people are exposed to public priming, either from an individual nurse or medical doctor. So that's a positive news. And the good thing about this is that this strategy works either for high or low vaccine skeptic people. So if you just share and share and share information on social media, you never know. You might change a person's life. You just have to share. Next, in terms of perceived expertise. So public priming can also work. It elicits people who engage in public priming, whether an individual, nurse, or doctor, people seem to perceive that they're experts because they're sharing some credible information. And in terms of public rebuttal, the interesting thing that I found here is that it's only for individuals and doctors. Those exposed in the nurse group that engage in public rebuttal, it wasn't really associated with perceived expertise. So that is one caveat for this study. And eventually, when people think that the person sharing that information is an expert, they're more likely to take the COVID-19 vaccine. So unfortunately, the results are only for the low vaccine skepticism. So it didn't really work for the high vaccine skepticism. So in general, I would like to share 5 lessons learned from this research. So correcting misinformation works. You might not see it that it's working, but it actually works. You might not know, you won't really know sometimes who are the people that you are really giving the correct information, and that might have changed their idea. So correcting misinformation works, and there are different strategies. You can do public priming, you can do private priming, you can do private rebuttal, public rebuttal. It's really up to how comfortable you are in doing this. But at the minimum, I would suggest doing public priming. If you don't like debates or getting into heated arguments, you can avoid public rebuttal. You can avoid private rebuttal, but at least you can do public priming. Next, I would urge healthcare organizations to incorporate, and also health educational institutions to incorporate social media and misinformation training, because that's providing health information is not only during clinical encounters, but future and current healthcare professionals need to know how to share that information on social media platforms, because that is where people are. And there's this new COVID-19 vaccine communication handbook authored by a group of people that's headed by Lewandowski. Next is organizational support is essential to encourage correction. So there should be organizational backing. One way that organizations can support healthcare professionals is by simply providing the training and giving them instruction that they can engage on the public, like really specific memo that you're encouraged to engage with the public so that you'll be able to correct health misinformation. Finally, there needs to be a normalization of correction. When you do corrections and when you do some public priming or public rebuttal, you can insert hashtags like MedTwitter, Nurse Twitter, so that other people can learn from it, so that it becomes much more visible to a wide array of audiences, so that people can also learn how to correct misinformation. If you put that hashtag, they can be able to link at with that hashtag. So overall, those are some of the lessons that I learned from this research, and I'd like to thank you for your time, and I do acknowledge my supervisors, Yanzang Yasit-Wiska, for the guidance, and also for the Bullard and Boyvey Fellowship of the UTI School, which enabled me to do this research for the past 2 years. Thank you very much.
All right. Thank you so much, Dr. Bautista. That was extremely interesting, especially it's encouraging to know that correcting misinformation works and to find out how we can do that. Do we have any questions for Dr. Bautista?
Don't have any questions in the chat yet, but perhaps one of our panelists might have one, or someone wants to chime in.
So I had a question. When you say incorporate social media and misinformation training, what does misinformation training look like?
Yes, misinformation looks like first introducing what misinformation is and how it's different from disinformation. So it's all about learning what the nature of the problem is. Even for some people, they might be misappropriating terms like misinformation, disinformation, and even fake news. So how are they different? Next is that what's the nature of misinformation? What are the types of misinformation? One of the problems with misinformation is that, for example, vaccine hesitancy is a form of health misinformation. But in terms of my research, there are other misinformation like sarcasm, there are some misleading pictures, manipulated posts. There are different ways of presenting misinformation. Next, a training would also include, for instance, how do you deal with it? So by using my framework, we can do a step-by-step guide on how people can react to that misinformation and the ways that they can share the correction to the misinformation. So there are different ways. I think the common belief is that you can only provide correction to misinformation if you engage in public rebuttal, like really debate. Because it would have social utility wherein people can actually see. But the problem with social media is sometimes it gets flooded. So if you debate with people, sometimes the post wouldn't be seen by most people because sometimes it's buried below. And that's why at the minimum, I would suggest that people do public priming. It means that once you see a health information, like CDC tweeted something, and you see that it's really relevant and really helpful, you can just retweet that post from CDC and put in some of your insights, like what Professor Hotes is usually doing. So Professor Hotes sometimes engage in public rebuttal, but it's very seldom. He usually performs public priming, and that information can be shared by most people, and we hope that it becomes viral. And if you look at this diagram in this summary, there's some you can actually save people from misinformation if they somewhat see that correction, whether it's from public priming, private priming, or other forms of corrections.
Fantastic. Thank you. Thank you
Welcome.
for answering my question. Do we have any other questions?
We have a few more questions. I'm going to combine two. One is the first question being any resources available besides the handbook, and what training is currently available?
I think that's something that's my future research direction. So I actually asked this to some of my interviewees. Is there a formal training at the school level? First, there's not. So some students might be taught what social media, but not necessarily like they may even be taught what is misinformation, but not necessarily going deep dive. How would you correct someone? So that is something that educators can actually think of when revising their health communications curriculum, to also include communicating on social media. I think that's very important. Healthcare professionals, doctors, nurses, and different healthcare professionals, they have this professional identity to become information agents. And being an information agent is being able to share correct information to the public, and the public is now on social media. So you also need to learn how to share that information on social media. So that's one of the things that needs to be worked on. So this handbook is a start, but we also need to somewhat take a look again with our health communication, health information handbook. And I think that would be in terms of the curriculum, and that would be one of the first steps in doing so.
All right. Thank you so much, Dr. Bautista. We are out of time. Extremely informative, very enjoyable, and we wish you luck in your future research. So you'll continue to educate us about this.
Yep.
And with that, it is my pleasure to turn the moderation baton over to Dr. Wilson. Dr. Wilson.